All right, I think we're going to go ahead and get started. Welcome, everyone. Welcome. It's great to see all this energy. Thank you so much to our visitors who are here visiting us with the Next Steps group. Thank you so much. It's a pleasure to introduce our speakers today. So we have two speakers. Cathleen Colon-Emeric, who is a professor of medicine and chief of geriatrics and palliative care at the Duke University School of Medicine, is here with us. Her research focuses on topics such as prevention of osteoporotic fractures in older adults and improving quality of care for residents in skilled nursing facilities. She has led a number of large randomized controlled trials in these SNFs, including a comparative effectiveness trial of models of post-acute care after fracture in 42 different facilities, a randomized trial of a multifactorial osteoporosis quality improvement program in a number of facilities, and then a staff development program for fall prevention in 24 facilities. So really incredible body of work here, and excited to hear more from Kathleen. We also have Dr. Sarah Berry. Sarah Berry is a geriatrician and a clinical researcher with expertise in studying injuries among nursing home residents. She is an associate scientist and associate professor of medicine at Harvard Medical School and Beth Israel Deaconess Medical Center. Dr. Berry is currently the MPI of a large trial to determine the effects of de-prescribing care model and an osteoporosis treatment model on rates of injurious falls among patients receiving post-acute care in nursing home following a fracture. She has a K-24 award, which allows her to precept trainees on projects related to injuries in older adults and nursing home research. So really a great combo. We get both of them today. I'm excited to have both of you here speaking. So thank you, and I'll hand it over to you.
Thank you so much for having us. We're very honored to be here. Our disclosures are here. We want to particularly acknowledge the funder of the trial that you're going to hear about today, which is PCORI. So we're going to share with you a little bit about some of the design challenges, some of the options we considered, and some of the decisions we've made in the context of our PRISM trial that you're going to hear more about today. As Kathleen Unruh mentioned yesterday, there are design issues, and then there are also the engagement, recruitment, retention issues that are equally important. So I'm going to start us off with some of the design decisions that we've made, and then Sarah is going to bring us home with the engagement. And we also want to hear from you, right? So what would you have made differently? What other approaches should we have considered? What are other engagement strategies can we continue to adopt as we're going through this trial that's currently in progress? So here's the clinical problem we're trying to address. There's a fracture, an osteoporotic fracture in an older adult somewhere in the world every 3 seconds. And 2 fall-related deaths will occur in the US in the time we're here together in this hour. If you are over age 50, 1 in 3 women and 1 in 5 men are going to have an osteoporotic fracture in their remaining lifetime. And in fact, you are more likely to die from the complications of an osteoporotic fracture than either breast or prostate cancer. The US spends $50 billion annually on injurious falls. And after an osteoporotic fracture, 1 out of 7 people are going to have another injurious fall or fracture within the next year. Although many patients, and frankly, a lot of my colleagues, feel like osteoporotic fractures are inevitable as we age, I like to tell folks that a major osteoporotic fracture should be considered a bone attack, equally as serious, and should get our attention just as much as a heart attack. We have similar 1-year death rates following a major osteoporotic fracture, similar secondary event rates. So 1 in 5 people are going to have another injurious fall or fracture in the next 2 years. And we have evidence-based medications that reduce not only secondary event rates, but also mortality after osteoporotic fracture. These medications also have a big impact on quality of life. And yet, in the US, what proportion of patients after an acute MI are going to be discharged on a statin or a beta blocker or an aspirin? What do you think? Shout out numbers. It's higher. It's over 90%. We'd be shocked and horrified if we admitted to our nursing facilities a post-MI patient who wasn't on aspirin and a statin. What proportion of patients receive bisphosphonates, these evidence-based mortality-preventing drugs after a major osteoporotic fracture? It's more about 10 to 12%. So we have a huge treatment gap that we really need to address here. So we are really focusing on medication optimization after osteoporotic fracture for two reasons. One is because only 10 to 12% are actually treated with evidence-based therapies after a major osteoporotic fracture. Prior work has shown that this is kind of due to their multiple transitions in settings of care and the resulting diffusion of responsibility around that. The other side of the equation is that 90% of folks coming into skilled nursing facilities after a major osteoporotic fracture are using one or more fall risk increasing drugs. Those potentially inappropriate drugs or risky drugs that are going to increase their chance of having another fall and injury. These also can make folks sleepy and interfere with their recovery. And we know that these medications persist. So even at 6 months, an average of 3 to 4 fall risk increasing drugs per patient in this population. Why are we focusing on post-acute care? Well, 60% of patients who are hospitalized with a major osteoporotic fracture are subsequently discharged to a SNF. So this is the major post-fracture setting of care. And the folks who go to SNFs are more likely to be frail, have cognitive impairment, multimorbidity, and therefore are at the highest risk for recurrence and least likely to get treated. Focusing on post-acute care also gives us an opportunity to adjust medications in a controlled setting where we can monitor for adverse drug withdrawal events and make sure that they don't have recurrence of symptoms. It helps us to overcome some of those transition barriers I was alluded to. And it gives us an opportunity to think about locations for subsequent implementation, should the care model be successful within nursing home chains or within nursing home collaboratives around major health systems. So we are really trying to leverage that, 2 weeks on average that folks are spending in post-acute care after an osteoporotic fracture with a little bit of additional resources to optimize their medications and subsequently improve their outcomes after a recent osteoporotic fracture. So the objective of the PRISM program is to conduct a randomized cluster crossover trial in fracture patients who are receiving post-acute care. And we're comparing the effectiveness of 3 different care models: a deprescribing care model, a bone health model, and a combined model on rates of injurious falls and other patient-centered outcomes. We are going to be enrolling 42 nursing facilities across the country. We're currently live in 38, so 4 more facilities, if you want to raise your hand and sign up, please see us afterwards. We are taking folks who are participating in the long-term care data collaboratory, which I'll tell you more about in a little bit. And we're taking larger facilities so that they have enough fracture admissions per year. We're targeting folks who have at least 400 post-acute care admissions annually. Ultimately, within those 42 facilities, we expect to engage over 3,700 patients who are receiving post-acute care after an osteoporotic fracture. We're taking nearly all comers, only excluding those that aren't osteoporotic fractures. They're related to cancer or infection or fingers or toes or skull, or if the patients are eligible for hospice or palliative care. And this is a general overview of what our care model looks like. We are using a centralized case finding and intervention model that's sort of led by a post-fracture nurse consultant who is remote from the nursing facility and supported by an interdisciplinary team. This post-fracture nurse consultant is notified when a patient with fracture is admitted to the facility. They review the electronic health record for the discharge summary and the nursing notes and the MAR, the current medication administration record. They develop a draft medication optimization plan that they then review with our interprofessional team, which includes geriatricians and geriatric pharmacists and osteoporosis experts. They then call the patient and family to conduct a shared decision-making call, understand what matters most to that patient and family, and review some of the recommendations that may be made on the medication optimization plan. If the patient and family agree and it's consistent with their care goals, they will then give this medication optimization plan to the staff at the nursing home. including the medical providers, to review and decide whether or not they want to implement that. They will also give a copy to the patient and family member and to the primary care provider so that everybody's on the same page. And then they will continue to follow the patient by phone and provide education and follow-up to 30 days, 90 days, 6 months, and 12 months, even after they've left the post-acute care facility. And these medication plans are focused on one of three things: reducing fall risk medications, osteoporosis management, or both. So again, these are the three things that we're ultimately going to compare at the end of the day. And we are also going to have control facilities that aren't participating in the program at all, and we'll be able to match residents in those facilities with participating residents in our intervention facilities and be able to compare injurious fall rates and those folks as well. This is what our medication optimization plan looks like. This one happens to be for deprescribing and for the nursing facility prescriber, but it basically summarizes what matters most to the patient, what the patient has agreed on, and the recommended tapering orders and monitoring orders. And the provider can choose whether or not to implement that or modify that, and will get hopefully implemented in the SNF. We also have developed lots of patient education materials and non-pharmacologic treatment strategies to address some of the common symptoms in post-fracture patients as we're trying to taper off some of those risky medications. This is just a sampling of them. And that brings us to our first design challenge that we wanted to talk through, which is what would be the appropriate unit of randomization for a trial that's trying to compare these three care models. The one option, of course, in a traditional randomized controlled trial would be to do patient-level randomization. And there are certainly some pros to this, right? That's going to give you the smallest sample size requirement, and it's going to give you the best possible chance of balancing all of those confounders, all of those covariates across the three care models. The cons to this is that it will almost always require individual patient-level informed consent, which is a real challenge in nursing home residents. And more importantly, or equally importantly, is likely to result in a poorly generalized sample. You're going to have a selection bias, a healthy volunteer bias that is especially problematic in your post-acute care residents. The other issue that we have to worry about for patient-level randomization in nursing home trials is the risk of contamination. So if the patient in room 101 is getting a deprescribing plan and the patient in room 102 is getting an osteoporosis plan, the staff is going to scratch their heads and say, hey, what's going on here? And there may be spillover of the intervention into the other residents who you don't want that to happen. So the other common level of randomization in nursing home trials is a facility level randomization. The pros here is this minimizes the chance of contamination, which is often a big thing, and it gives us the potential to have a waiver of informed consent at the individual patient level, and therefore a more generalizable sample, assuming the intervention that we're talking about, like ours, is considered standard of care best practice recommended by guidelines. The con here is that you pay a sample size cost for the clustering of patients within facilities because those patients are more likely to be similar to each other than in the larger patient population. And because you're randomizing a relatively smaller number, 42 instead of 3,700, we risk disparate groups across our three care models, even if we try to match facilities and stratify our randomization as much as possible. There's always a saying, you've seen one nursing facility, you've seen one nursing facility. The patients that they care for, their setting of care, their environment are just going to be very different. And so if you have to worry more about confounders at facility level randomization. So where we landed was at a cluster crossover study design. And in this design, all of the facilities are going to receive all three care models in random order. So for 6 months, they'll get maybe the deprescribing model, and in the next 6 months, they might get the combined model, and then the last 6 months, they might get the osteoporosis only model. Patients, the day that they are admitted to the facility, that determines which care model that they are given, even if they remain in the facility after it's switched over to the next care model, or they're discharged. And we're censoring patients at death, and we're measuring patient-reported outcomes at 90 days, again, regardless of whether the patient's remained in the facility or has been discharged. Again, we're going to be comparing injurious falls and fractures across these three intervention types, and also with matched control facilities that we're matching in a 3-to-1 ratio. So that's the design we landed on. Which is great. It minimizes our clustering. It minimizes our sample size in a cluster randomized trial, but it gives us this additional challenge of having to worry more about contamination, because now we have not room 101 and 102, but we have on January 1st, they were getting osteoporosis. Now on January 2nd, we're switching over to deprescribing. And are the providers in the facility going to change their behavior across those different intervention periods? So we thought a lot about this and what we could do to try to minimize this. So we talked about yesterday, changing prescriber behavior in nursing facilities is really, really hard. I have been the painful PI of other prior educational interventions, quality improvement interventions to try to improve osteoporosis care in nursing facilities that have failed miserably. So we think that this is relatively lower risk and yet something that we need to consider carefully. We thought about having a washout period between those three periods. That would have an impact on our timeline and our budget, and it wasn't really clear to us what would be the right washout period that would work for this. We initially planned to actually have distinct nurse care fracture managers delivering each intervention. So one nurse only does osteoporosis and one nurse only does deprescribing and one nurse only does the combined model. That turned out to be impractical due to licensure issues. We'd have to have all of our nurses licensed in all of the facilities that states that our facilities are located in. And more importantly, the importance of relationship building between our nursing homes champions and the fracture liaison nurses who are delivering the intervention, and that was so important. We didn't want to disrupt that by changing 3 times over the course of this study. So at the end of the day, where we landed is that, the study team control the intervention content as much as we possibly can. We know what intervention period the patient is in and what they should be getting. There's a double check on the medication optimization plan to make sure they don't accidentally get deprescribing recommended when they're in the osteoporosis period. And we have standardized scripts and standard operating procedures, manuals for our nurses, and special training for them on how to respond when a prescriber or a patient or a family member asks them about a component that isn't applicable to that patient's care model. We also have planned in our analysis to assess any impact of contamination and measure how much contamination we might be seeing. The second design challenge that we really faced was what measures should we be looking at in this trial? And these were the key considerations that we wanted to pay attention to. First and foremost, they need to matter to patients and other partners, the nursing home facility staff, healthcare administrators, payers, health systems, the medical team, the nursing home staff, and so on. Of course, as in any research setting, they need to be valid and reliable. Ideally, we'd like to leverage measures that are already routinely collected in the nursing facility to reduce the burden on patients and staff, as well as our study costs. And if they are not available, we need to really think carefully about that burden, because it's particularly problematic for patients in the post-acute care period who are already feeling overwhelmed and in pain and experiencing rehab. We don't want to add to that burden. Because there is such a high prevalence of cognitive impairment in skilled nursing facilities, we needed to select measures that are also validated for care partner completion so that we have the option of either or. And they need to be accessible, and considering patients who might have sensory impairments or different languages. So we have a nursing facility that's 98% Spanish speaking, for example. So we had to make sure all of our measures were translated and validated in Spanish. So these are the outcomes that we landed on. The top three are in green are our pragmatic outcomes that are sort of already routinely collected that aren't adding additional measurement burden. And that's injurious fall and fracture rates as measured by Medicare claims, osteoporosis treatment and adherence rates, and fall risk increasing drug use as measured by Medicare Part D claims. But during our co-design phase, which was kindly funded by the NIA, thank you, Marcel, we heard a lot from patients and caregivers and family members and nursing home staff that there were other patient-reported outcomes that were of interest that they really wanted us to consider measuring. And so we also are getting patient-reported outcome measures via survey over the phone at 90 days, including medication side effect burden, a fear of falling instrument, and then some safety outcomes. Are we changing pain, depression, anxiety, agitation, or sleep as we're particularly deprescribing medications in this population? We were able to leverage this wonderful new resource, the Long-Term Care Data Cooperative, and our partners there in helping us to, particularly with the pragmatic administrative measures. If you don't know about the Long-Term Care Data Cooperative, I'd highly recommend that you get to know this wonderful group. They have EHR structured data from two of the largest EHR providers in skilled nursing facilities, and they have a contractor who actually has the ability to extract text-based data elements in addition to the standardized data elements there. They also have MDS data and Medicare data for their participating facilities, and their goal is to have well over 1,000 facilities at the end of the day. And maybe we can hear from Giff and Stephanie. How many do you have now? 2,700. There you go. So it's a fantastic resource, and where I understand that we're one of the first large studies that have been partnered with a Long-Term Care Data Cooperative. So we're learning a whole lot about this data and how it's structured and how we can use it. Here's an example of what Andrew Zullo and his team have been starting to work on in terms of preparing to analyze the data that we're going to generate in the PRISM trial. This isn't from our study patients, but it's from a group of almost 15,000 patients who were admitted to skilled nursing facilities after a fracture. And it's looking at pain scores from the MDS and how they change over time. And gabapentin, weekly gabapentin dose, and how it's changing over time as well. So lots of data that requires lots of expertise in managing. So we're very grateful for the partnership of Brown University team as well. So a lot of you are actually sitting there scratching your heads and going, just how pragmatic is this trial anyway? You called it a pragmatic trial. And in fact, we recognize that although we're pragmatic in some elements, we're less pragmatic in others. So eligibility, we're taking pretty much all comers here. Patients don't have to sign informed consent. We have a waiver of informed consent as gold standard care. They can opt out of talking to our nurses, and that's just fine, but they're still going, their facilities are still going to get the medication optimization plan. Their primary care providers are still going to get the medication optimization plan. Trials being done in a wide range of real world facilities that patients will tell, that Sarah will tell you about in a minute. We are adding some additional staff and expertise and resources. That's kind of the heart of our care model, a centralized care team that's supporting the facility and doing some of this time-consuming medication optimization work. So that's less pragmatic. And although we have certainly allowed the facilities to tailor how they're implementing and interacting with our care team to minimize the impact on their workflow, there's still core components that they have to deliver. And we are actually having our study team follow patients for adherence with the recommendations over time. However, we're using administrative data for follow-up. Our primary care, primary outcome is available in administrative data and is highly relevant to patients and other stakeholders. And we're pretty much including all data in our primary analysis. So we're kind of a squished pragmatic. And with that, I'm going to turn it over to Sarah to start telling you about our approaches to patient engagement.
Great. Thanks, Kathleen, for that great introduction and design. And as she mentioned, I'm going to talk now about, how we're doing with recruitment and our strategies for engagement. So starting with recruitment of facilities, again, our goal is 42 facilities. We've got 38 so far with stars shown in the states where we have current participation. And as you can see, we've done pretty well with respect to geographic diversity. In addition, we've achieved some differences with respect to the quality rating system. 37% of the facilities have 4 to 5 stars, 37% 3 stars, and fewer numbers 1 to 2 stars. In addition, we've been trying to preferentially recruit facilities that have some racial ethnic diversity. And 34 of the facilities that we've enrolled are admitting at least 14% Black and/or Hispanic patients each year. With respect to patient enrollment, this orange line shows our projected enrollment. The green shows our actual patient enrollment. And we got off to a really good start. You can see we're just a little bit behind, again, largely because we had hoped to enroll all 42 facilities by now. We feel like with the upward trajectory, once we get these final facilities in, we should be back on track. And so also with respect to patient recruitment, in total, our nurses have assessed eligibility for over 2,100 patients in these 38 facilities. And just over half have been excluded, most of which because they don't meet the eligibility criteria. And this was pretty simple eligibility criteria. This is, again, often a patient where it was a hip replacement, it wasn't a fracture, or the patient is on hospice palliative care. As Kathleen mentioned, we're an opt-out program, and there have been 105 patients that have opted out of all further contact. And then again, there's been 368 instances where the patient has been discharged or died before we were able to deliver the intervention, right? These are the patients that go back to the hospital so quick, it's a revolving door, and there's simply not enough time to enroll them in our program. But as of the end of August, we've enrolled just over 1,000 patients, so almost a third of a way to our target. The slide here shows also those 90-day follow-up calls that Kathleen was mentioned in here. We are a little bit behind. It's been challenging, and I'll talk about this more in future trials, to date reaching just 49 patients. So patient characteristics of those 1,000 or so patients who have been enrolled, I think you'll agree, we are really a pragmatic trial, and we truly are getting an older, sicker population. The median age is 82, again, ranging between 65 and 102 years of age. 34% of our patients have just suffered a hip fracture, 14% a vertebral fracture. And while we know that dementia diagnosis is widely underreported in the chart, we're picking up at least 22%. Right? So we've used really a multi-pronged approach to recruiting and engaging facilities. And that really starts with a strong partnership with HCA, Stephanie Kissam and David Gifford here. Are really partners and co-investigators in the PRISM trial and have been making that initial outreach to facility leadership. Once we find engaged facility leadership, we're turning it over to our project director to identify those local contacts and startups. And I would say that initial contact is really key. We're fortunate to have a strong project director who's worked as a nurse practitioner in nursing homes for more than 20 years. She speaks nursing homes. She does a great job of bringing them in that initial contact. One of her jobs then is identifying site champion, and I would say site champions, ideally, because we anticipate turnover. And I'll note that the site champion need not be the director of nursing or even a nurse. Really, we're finding that some of the most engaged champions come in less typical roles. We have one facility where the champion is the admissions coordinator, another where it's a pharmacist. I think really the message is anybody who's really passionate about this and wants to step up and feel strongly about reducing medications and preventing falls is the right champion for us. There is some compensation provided to the facility, $7,500 a year to offset the time for the champions. On the champion level, we've been trying to engage them with small gifts, some bags with our logo and pins. I'll note we were really excited as investigators about these pins. We thought they looked great. We really haven't heard a lot of feedback from the facilities about them. But when we sent cookies, we heard great things. And we are now sending a second round of cookies. Would highly recommend those. Newsletters, we've developed a newsletter not only to engage our stakeholders for the PRISM trial, but also to show progress again to both facility leadership as well as the champions and frontline workers. And then finally, fidelity reports that are going out to the facilities quarterly. Here's an example of the fidelity report for the facility, again, where you can see they're getting quarterly feedback to the champion on how many of the medication plans are being returned, how many patients enrolled. You'll note that we really aimed for very positive language here. Nonetheless, we've had some feedback that the champions don't necessarily like to hear that the physicians aren't returning the MOPs because they feel like they don't have control over that. And so we're working right now, again, to modify these reports. Certainly despite the successes, also some challenges in keeping facilities engaged. First lesson learned, I think, is that interest from corporate does not necessarily equal interest locally. And this was particularly true with one large chain where we had a strong interest from corporate, less so, again, from local leaders. And in that case, we actually ended up having to withdraw 6 nursing homes because we were simply not able to engage, not able to enroll any patients in those facilities. Second challenge, which we all know in this room, is turnover. Expect turnover. We had one facility where, again, the champion left and there was not another co-champion. In this case, there was really a 2-month period until that was reassigned where we were unable to get any enrollment at that facility. We've been working with our statisticians on how to handle that, and what's been recommended, again, given the study design, is that we'll have a pause rule only if it's for external factors that prevent enrollment, something like a flood where there were no admissions to the nursing home. But if it's something internal, again, a turnover in the spirit of this pragmatic trial and care delivery, we are continuing. We've certainly set up it's caused us to set up more rigorous administrative withdrawal rules that we fortunately haven't had to use to date. Another challenge is getting access to these providers. As a nursing home provider, I was somewhat surprised that the nurses were so protective and reluctant really to give us the information about their providers. Some facilities really not even willing to give us the name of providers. We've been working to build trust over time, Cathleen and I having one-on-one conversations with the providers because it's really critical for them to understand this program, right? And I think we've been doing a better job as we've been onboarding facilities at making it clear that this is just part of the onboarding processes, that Kathleen or I need to have a short conversation with your providers to explain the program and address any questions. And then finally, I would say DPH. Just like you've seen one nursing home, you've seen one nursing home, you've seen one DPH. They're all a bit different. Certainly, we learned that with one facility and the way they interpreted making sure that they documented that patients had a choice in participating in this program and negotiating that within their interpretation of DPH and the expectations there was challenging but doable. So also important, clearly, to engage patients, right? And this starts, our nurses are making a cold call to sick patients while they're in a nursing home after a fracture to talk about their medications. And so it certainly works best if the patient or the family member is expecting that call. And so we've developed a flyer that is so general. The front page is shown here, the back page not shown, sort of giving them a heads up that this call is coming, and sort of we've made it so general that it can be put in every admission packet. I'll note that there's really a lot of variability across the facilities in how this flyer is being used. And again, this speaks to some of the more pragmatic aspects of this trial. We have one champion that is hand delivering this to every eligible fracture patient and telling them, hey, they're going to call you, pick up the phone. We have other facilities where I suspect they're not using this flyer at all. So again, it's certainly time and patience. Even if patients are tipped off to the call, again, these are sick patients, these are busy proxies, family members that are at work and juggling multiple things. And so it's certainly taken some patience and persistence to get through with these calls. We find that about 37% of the patients that we reach out to, it takes 2 to 3 calls to get somebody to pick up. And then sometimes, even when they have a rather lengthy conversation with a patient, the patient says, I'd really like you to also talk to, my daughter, the proxy. And so sometimes the nurses are having yet a second conversation, again, in order to engage. That being said, I'm really delighted to say that with patience and persistence, our nurses have been able to reach about 60% of the patients, these 1,000 patients, while they're still in the SNF. 50% of those patients, they're able to reach at 1-month calls, not always the same patients, sometimes picking up new patients later. Another way that we're trying to engage with patients is to be sure that our recommendations really align with patient priorities and what matters most to him. And as part of the standard operating procedure, the script that our nurses are using when they're making these phone calls, they're asking patients about their patient priorities. And here's a few examples of questions that they might be asking. As you're recovering from your fracture, tell me what matters most to you. Tell me some of the reasons that X is so important to you. And now that I understand that X is so important to you, I'd really like to talk with you about how program can help you achieve your goal of X. And we're excited about obtaining these matters most questions and just starting to take a peek at the data. So again, of those first 1,000 patients enrolled, about 600 or so that we were able to contact in the facility and obtain this matters most question on, with the results shown here. You can say by far and away what's most important to patients in post-acute care with a fracture is getting back home, perhaps not surprisingly. And sort of a second priority was function and regaining function. About 30% noted that comfort was of great importance to them, and about 34% prevention. And you'll see survival there just less than 2%. Our nurses are noticing some interesting differences, whether they're getting this information from the patients or from the proxies. We're excited about exploring this data a little further. So also certainly some challenges in engaging patients. First is that there are gaps, as Kathleen mentioned, built in between these phone calls. Our nurses are calling while they're in the skilled nursing facility at 1 month, 6 months, and a year, right? But the nurses are often noticing that sometimes patients have forgotten in between. They're having to sort of, it takes a while to rebuild trust, and this is a rather long gap between phone calls. Second, as we mentioned, this is all a remote intervention, right? The nurses are not working at the facilities where the intervention is occurring. And so you can imagine to a family member, to a patient picking up, this is going to look like a spam call. We've tried to get around that by working with the 2 major phone carriers, AT&T and Verizon, and sort of changing the ID when the phone number pops up, that at least it has our PRISM name on it. But we recognize that certainly that's not reaching everyone. Another real challenge with this patient population, again, is that many do not have smartphones, and almost none of the patients have or prefer to use email. While we're offering that 90-day survey, primarily we're collecting it while, verbally while we're on the phone. We've additionally added an IRB amendment to allow for paper surveys because some people have requested that. And then another challenge is PCP engagement. It was really surprising to me that about a third of the patients that we've enrolled to date cannot tell you who their PCP is, and there is no PCP listed in their medical records discharge, talk. On the other hand, you have some patients that don't want to make any changes in medications without talking to their PCPs, right? And so the nurses have had to really juggle this very sort of disparate relationships, but important relationships with PCPs. And then finally, again, this 90-day calls in a sick population has proved challenging. We knew this was going to be challenging, and pretty quickly we decided to implement a postcard and send a reminder for the 90-day call to tell people to expect it. We developed this with the input of our stakeholder advisory committee, sort of two-sided postcard, simple shown here, just really encouraging people to take the time, pick up the phone. It has remained challenging, and you can see here, again, our overall success rate with these 90-day calls. We've added some additional strategies. We've hired a per diem nurse, for instance, that primarily works on weekends and at nights when the proxies are more likely to be willing to complete the surveys. And our overall success rate right here, this was as of the middle of August, about 11%. We're hoping to get that closer to 20%. So our statistician has reassured us that despite the fairly low completion rate of these 90-day surveys, we are in fact powered to detect differences. But I guess the question remains is whether the results will be generalizable. And certainly looking at the data preliminarily, there's some concerns that there are differences between our respondents and non-respondents. On the left, you see the characteristics of our full PRISM cohort. On the right, those that responded to the 90-day survey. And not too surprisingly, those that responded are younger, they're less likely to have had the bad hip fracture, and they're less likely to carry a dementia diagnosis. And so to address this generalizable issue, we are working with our funding agency and also our stakeholder advisory board with a plan to add some qualitative data in a subset of these patient telephone calls to get additional information for this vulnerable population. Next, I would say it's been important to engage our nurse interventionists. And you'll see here we have 6 interventionists total working on this, 5.5 FTEs. Each of them really came to us with a very unique background, some with strong, long history in nursing homes, but no research experience. Others very skilled with research, but no experience in working with older adults. And so we made sure that the training that we offered was the same to all of our nurse interventionists, that it was standardized. Certainly one important piece was working with a behavioral psychologist, Maggie Syme, on motivational interviewing and shared decision-making that's really fundamental in these outreach calls. Additionally, we're looking at the fidelity, the quality of the decision making across, again, having so many different nurses deliver the intervention. Each of the nurses has an observed call at baseline, and then every 6 months with a change of the care model to assess for fidelity. And we're assessing fidelity using a modified option MCC score. Okay, so this is a 7-item tool where we rate on a score, the observer rates on a score of 0 to 2. Did the nurse interventionist engage, elicit goals from the patient? Did they provide the patients their options, et cetera? So we're excited about that data. Our nurses are getting quarterly feedback, just like the facilities are, again, with an example shown here. So things that the nurses are receiving feedback on include, what percentage of their medication plans were delivered within 10 days of admission, and how often, what percentage of the SNF providers are acknowledging their plan. It also includes the percentage of 30-day calls completed, 6-month calls completed, and again, this score on the modified option MCC. So just a little bit, again, a pragmatic trial. 100% of the patients enrolled are getting a medication plan that is delivered to the facility, right, and delivered to the patient, right? But we don't always, we're less successful, obviously, and don't always know in whether the SNF providers are acknowledging this. So today we've got about 64% of our medication optimization plans where the SNF provider has returned it and acknowledged, again, our plan. In 69% of the cases, we've been able to identify a PCP and send the plan along to the PCP. So closing then with some take-home messages. Nursing home trials are fun, but they require careful consideration of study design, recruitment, and data collection strategies. And I think Kathleen really did a wonderful job of illustrating that there's no perfect study design here. You're going to have to make some trade-offs. Be sure to leverage partnerships that you have when recruiting these facilities. Be willing to be creative, nimble, and flexible. I think engagement is critical, and it's got to be engagement on multiple levels, right? What's going to engage the C-suite is not the same as what engages the frontline staff and champion, is not the same as what engages the patients. And you need to use multiple strategies at all of those and adapt over time. And really delighted for the opportunity to talk here and the next steps. And it's really exciting to get a group of researchers together that are excited about nursing home research and are really building tools and training to help the next future generation engage in studying this understudied population. So, thanks. And I think we've left about 10 minutes for questions, so certainly happy to take questions from the audience or others.
And so in doing that, we've discovered a lot of the studies have an upper age limit, and it excludes 80% of the people living in those communities. So I saw you had a 102-year-old. And so I'd just love to hear how you've handled that with your IRB and what your recommendation is for others who would like to extend their age enrollment criteria.
Yeah, that's great. So this particular study, we had a waiver of informed consent. Again, it's considered best practices for anybody, whatever your age is, to review your medications after you've had a fracture. And so they'll participate in the program. Now, that being said, we did develop, if somebody is on the bone health arm, we did develop sort of a specific algorithm and sort of looking at life expectancy and whether or not we would recommend treatment. But regardless, they're eligible and they're part of our study.
Hello, great presentation, Arif Nazir, geriatrician. Quick question, your design of this in a project, and I've, just asking this question also. over the last few years, it has come apparent that every nursing home has, and I think Dr. Auslander was talking about that we're not using physicians as well, in quality improvement. Now, one thing which has happened, which has really helped us enter a new era, which I don't think has gotten into research designs yet. Every nursing home, you like it or not, has a nurse practitioner these days. Almost everyone. And I oversee 150 nursing homes, nurse practitioners. And as CMO, my go-to strategy has totally evolved from a champion strategy at a facility to go to my nurse practitioner being the champion, needless to say, for quality, for prescribing, quality improvement, conversations. And they don't have to work for free. Every single thing our nurse practitioners these days do is covered through CMS codes, which have gotten way better over the 10 years. So I don't know why we're not using in our research strategies these nurse practitioners to be the go-to, because we're already doing it, by the way. Our return to hospital meetings are done by nurse practitioners. Our deprescribing initiatives are done by nurse practitioners. Our gabapentin deprescribing initiatives are being NPs, and they love doing them because they actually get paid and you can set accountability and whatnot. So just want to throw that out and also ask that, has that come up as an idea among your conversations for design?
Yeah, it's a great point, Arif, and we would love to be able to adopt that. We've seen a lot of heterogeneity in how facilities are set up in terms of their medical providers and how willing they are to connect us with their medical providers. So in facilities where there is an APP there who's there a lot and we've been able to connect with that person, it's been awesome. They've been on board. They've been great at returning the plans and implementing these things. We still feel like we need another facility champion besides the APP to do some of the logistical stuff. So I notify us when there is an admission of a fracture patient, handle some of the paperwork, input the orders, those sorts of things. So it's a yes, and we want to engage the APP, and we probably also need a champion of another sort. But as Sarah mentioned, we have a lot of facilities who are like, oh no, you can't. You have to go through us if you want to talk to your medical providers because they're just so protective of them. And that's been an unexpected experience for us.
I will try to take that offline with you guys. There's many strategies we can talk about. A facility that protects their NP so much, probably not a facility you should be doing that work anyways, but definitely we can connect offline.
I appreciate it.
I think I'm just two quick things, and this will make it obvious. I'm not a researcher. I'm more of an advocate. So I'm paranoid about sending postcards because I feel like it's a HIPAA violation if you have any sort of medical thing in there and their names on it. So I'm wondering your thoughts on that. And that may be, obviously, apparently it's not a HIPAA violation. But secondly, where you have the three where they're getting both, they're getting the, deprescribing, and then they're getting, some treatment. What is the goal of the study, is to see if any of that works or one works better than the other, or is it, yeah.
So I can start with the postcard, and you're right. When I first drafted the postcard, I said something about recovering, and now you'll see the postcard says, "We hope you're well."
Okay. Okay.
We hope you're well. And the IRB was fine with that. So with respect to your second question, I've got to think. Wait.
The question was, you have the three different phases.
Yeah. So our hypothesis initially was that combining, right, that both deprescribing medications that are associated with fall-related injuries and providing treatment for osteoporosis would be the most effective way. We would have the fewest injurious falls, going forward, right? And so, we're comparing the combined model to each arm singular and to usual care. Now, that being said, the combined arm, while it might be, our hypothesis was that it might be the most effective in preventing injurious falls. You can imagine patients reported what they value with respect to their medications, fear of falling, those sorts of things. That may be more in deprescribing than it would be in osteoporosis treatment arm. And so, again, that's the rationale.
Right. Great. Thank you.
I'm curious, given that this is a PCORI funded study, how did you kind of navigate the engagement component and that sustained engagement for a pragmatic trial like this? And who were those partners, and how have you been working with them?
Yeah, great question. So we had a R01 funded to co-design the intervention and pilot it, and that was funded by the NIA as an R01 mechanism. And in that mechanism, we engaged PALT med leaders, we engaged nursing home medical directors, we engaged directors of nursing and administrators, we engaged frontline staff, we engaged patients and family members, we engaged some, actually we didn't initially, but we later realized we needed to engage some more funders, so potential funders for subsequent implementation. So now we have somebody from our population health management office at Duke, and we also have someone from CMS engaged. And we developed some co-design, and now we have moved to more of a stakeholder advisory board model where we meet with them quarterly. We have an in-person meeting in Durham coming up in a few weeks, and online throughout the year. We also have on our executive committee, we have two stakeholders, a family member caregiver who's also a patient advocate, and we have a former president of PALT Med who's on our executive committee who's helping us make a lot of these design decisions. So we've tried to be very intentional about getting all of those voices and paying attention to them throughout this process. It's been really critical.
Yeah, I'll just add, this was my, has been really my first opportunity to work with stakeholder advisory panels. And I've been so, I've so enjoyed, hearing the voice again, particularly of the caregivers and their needs when thinking about the design.
So Vince Moore, you've done a really, really nice job. I like the design. It is very elegant in terms of that. The one issue, of course, is whether you have a washout period. How did you think about sort of at a 2-week washout? Because you got about a 14 to 21 day length of stay, because otherwise you have somebody who's still there on the day they switch over. You sort of have a mix. How is your statistician going to deal with the mix? And because otherwise you have this wonderful facility fixed effect. It's very elegant.
Yeah, we tore our hair out about this and involved our statistician a lot. So we think it's okay because the medication optimization plan is going to be determined by the day they're admitted and what care model the facility is in then. So if a patient is admitted on one day and is in the combined arm, they're going to get both recommendations, and the patient the next day is only going to get the osteoporosis recommendations. And those are going to be what's carried through on all of the 30-day, 90-day follow-up. So because our study team is controlling much of what happens except for which of the recommendations the facility providers agree to, we felt like it was okay. But we did strongly consider a washout period. Probably might have been a good idea in retrospect.
I think, as Kathleen says, what we really struggled with, what is the washout period? Because as you know, there's some patients that never leave the facility. And so at the end of the day, I think this is where we landed. Yeah.
Hey, really cool study. And I never thought I'd be a comment more than a question guy, but I am right now. So in my impact funded pilot, I was providing these fidelity reports like you were, and I was meeting every month with our embedded staff who were implementing the intervention, and they were so, they were worried they were letting me down because they were recruiting 80% or something, which was amazing, which was way above our target, and they didn't understand that. So if you haven't, so first of all, they liked knowing their numbers, but then they were also sad because they thought they were letting me down. So as soon as I explained, no, you're doing well above what I wanted you to do, they actually felt so much better. So if you're not providing your targets to them, that might actually be really helpful. And for anyone else who's thinking about what to give back, people really do like seeing their data. That was at least my experience. So anyway,
yeah, thank you. Good comment.
Thank you so much. We'll welcome other ideas and suggestions throughout the rest of the meeting. Thank you for your attention today.